Welcome to everyone to today's webinar on public health transformation, really specifically on Indiana's workforce assessment process and plans. I'm Rena Chudgar. I'm the Director of Public Health Systems and Services at the Public Health Accreditation Board, and we're really excited to be here today with our webinar partners and presenters to talk again about Indiana's workforce assessment efforts. I want to specifically thank ASTO, NACCHO, the Indiana University Fairbanks School of Public Health, alongside our co-presenters from the Indiana State Department of Health and the Clark County, Indiana Health Department, joining alongside us here at FAB and bringing this webinar to fruition here today for all of you. So thank you so much to our partners and presenters for bringing this to life collectively. You'll be hearing from all of us specifically throughout the webinar and our time together today. A few quick logistics as you are getting settled. Please do use the chat to both engage with other participants and our presenters, as well as to ask questions of the presenters today. We will have a dedicated time for a Q&A and discussion after the presentation, so we'll likely save a lot of those questions for that portion, but please keep them coming throughout the presentation so that we can make sure we queue those up for the Q&A portion. And again, feel free to chat with each other and share ideas with each other in the chat box as well. For any tech questions, feel free to chat Naomi Rich or Lydia Aragai. They'll do their best to support you in troubleshooting as possible. We will share the recording and follow-up slides in a follow-up email after the webinar, so you can expect to get that from us in the next few days. Our goals for today are really to share how Indiana went about in conducting its comprehensive public health workforce assessment, how some of those data and findings are beginning to be used across health departments within Indiana, and to highlight and call out specific tools that were used and how they're available to others, and lessons learned to support your efforts in assessing your workforce and planning and implementing to transform your workforce within your context. So we're really excited to really provide this broad and in-depth overview of the work that Indiana undertook. If we go to the next slide, I did want to take a minute to ground us in what public health transformation is. Here's FAB's definition of public health transformation, which was developed with our staff and our 21st century learning community, who are statewide systems focused on public health transformation. Public health transformation requires reimagining and developing a common vision to ensure the mindsets, capacity, resources, and workforce necessary to provide equitable foundational public health services and essential public health services to advance health, well-being, and equity. It occurs through a fundamental shift in the way a public health system is structured, functions, and interacts through continuous quality improvement, innovation, partnerships, community-led efforts, and systems change. And I think you'll see how our presenters' work has connected into kind of really building towards public health transformation specifically. I'm going to turn to introduce our speakers now. I'll share who they are, and we'll put links in the chat so you can learn a little bit more about them and read their deeper bios specifically. In order of presenting, we have Pam Pontones, who's the Deputy Health Commissioner of Local Public Health Services at the Indiana Department of Public Health. Val Yeager, who's a professor at the Indiana University Fairbanks School of Public Health. Katie Hiltz, who's an assistant professor at the Fairbanks School of Public Health as well, and Eric Yazel, who's a health officer at Clark County, Indiana Health Department. These will be our speakers today, alongside Ashley, who's a senior analyst for workforce at ASTO, who will be sharing some of the resources that we have available to support your efforts, and Kathleen, who's a senior analyst for workforce at NACCHO, who will be moderating our Q&A portion later in the call today. So these are our presenters and the folks who you'll see today, and a thank you to Naomi and Lydia for support on the chat and tech as well to ensure everything runs smoothly. So without further ado, I'm going to turn it over to Pam now to share, to begin sharing about Indiana's work. Pam, I'll turn it to you.
Thank you so much, Rena, and good afternoon, everyone. It is my absolute pleasure to be able to share with you this afternoon information on where we are with Indiana's public health transformation and really the genesis of our local health department workforce assessment. In August of 20, well, I'll back up a little bit further by saying traditionally, Indiana has not fared well when it comes to public health. We fare very well as a state when we look at economic indicators, educational indicators, transportation. In several different areas, Indiana traditionally fares very well. But in public health, that's not so much the case. Our rankings comparatively to other states in public health indicators such as smoking, obesity, mental health, and others rank down in the lower quartile of states in the country and have traditionally rested there. The COVID pandemic, as with many states, really exacerbated some of those long-standing public health challenges that we have had as a state, and really shone a pretty bright spotlight on them. In August of 2021, Governor Eric Holcomb, our current governor, decided to use this opportunity of really where we were in the pandemic and kind of bringing to light some of those historical public health issues to take the opportunity and review Indiana's public health system in a comprehensive, holistic way. And so in August of 2021, Governor Holcomb convened really a blue ribbon panel of 16 individuals to serve on the Governor's Public Health Commission to really take an intensive look at Indiana's public health system, including the Indiana Department of Health, our 95 local health departments, and Indiana is a decentralized state. So those local health departments have their own legal jurisdiction over public health issues in either the county or the city where they are. And then Indiana's public health partners and looking at the system as a whole. The Governor's Public Health Commission was chaired by Dr. Judy Monroe, former state health commissioner here in Indiana and the current president and CEO of CDC Foundation. The other co-chair was former state senator Luke Kenley, a long-term state senator with a really renowned history of fiscal matters here in the Indiana legislature. Former Congresswoman Susan Brooks, who had quite an extensive involvement in bioterrorism and preparedness aspects in Congress, served as a citizen advisor. And then our then health commissioner at the time, Dr. Chris Box, served as the commission's secretary. Also included were several other representatives of public health, including our academic partners from the IU Fairbanks School of Public Health, Dean Paul Halverson, local health departments, local elected officials, including 2 county commissioners and a city mayor, and then several public health partners, including our Indiana Rural Health Association, Hospital Association, Public Health Association, a Minority Health Coalition, and several others, to look at Indiana's public health system in 6 different work streams. And those different work streams included workforce, funding, governance, infrastructure and services, data integration, childhood and adolescent health, and emergency preparedness. Our colleagues at the Indiana Fairbanks School of Public Health were participating in the research regarding the work stream, workforce work stream, to get an idea of what was going on in other states, what was needed at the time in terms of data regarding workforce. And that what was seen pretty evidently right off the bat is that we did not have really detailed granular data about workforce at the local health department level, such as numbers of staff, the capabilities of those staff to address the foundational public health services, comparisons from county to county. And that was really the genesis of looking at how do we get this kind of data and really systematically collect, analyze it, and distribute it. And that was really the launch pad for the local health department workforce assessment that you will hear in detail from Dr. Valerie Yeager and Dr. Katie Hiltz.
Thank you, Pam. So I'm going to be starting the conversation about our workforce assessment. And what you're seeing on the screen is the cover of our report, the Indiana Local Health Department Workforce Assessment. We released this report, which was conducted in the fall, just this past spring. And my colleague Katie Hiltz and I are going to walk you through how we did it. This was an undertaking that is noteworthy, and I know a number of states and other partners have reached out to find out more about how this process worked. I want to give just a moment of attention to the extensive project team that helped to make this happen. We had more than 10 of us at the School of Public Health in our Center for Health Policy, as well as an external partner, Steve Boddingheimer, who's a practitioner from public health departments, help us to execute this work. And as Pam mentioned, the national data on employees of governmental public health agencies does exist. So we did have some information about local health department employees, but it doesn't adequately reflect the local health departments in Indiana. In the most recent assessment from the Public Health WINS survey, so the Public Health Workforce Interests and Needs survey, which was in its third iteration, only represented 11% of Indiana's responses from outside their state health department or our large city health department, Marion County Public Health Department. So as Pam mentioned, the commission recommended that a step in strengthening the public health system in Indiana was calling for and collecting reliable information about the local health workforce and the health departments in the state. So we utilized 4 components. We contracted with the state health department to conduct this assessment, and we worked with them on planning. The first component of our data collection was an Excel spreadsheet. And this Excel spreadsheet was individual level information about every local health department employee in the state. And this gave an opportunity for 2 different approaches depending on the size of the agency. So each agency was provided the same Excel worksheet. For a larger agency, it was recommended that supervisors would work with their individual staff to complete a sheet. Those sheets could either be merged or all of them could be shared to us at the Fairbanks School of Public Health. Otherwise, if you were a small local health department, then the typical approach would be that the administrator would work with each of the employees in that agency to complete that individual employee's answers across a single row of the sheet. Given typical online survey response rates of 30 to 40%, the Excel tool was intentionally selected to leverage the administrator accountability within each agency, and that they could work with each of their employees to make sure that they were collecting data from everyone. We were trying to get a complete sample across the entire state. The next component of our data collection was an organizational survey, which we administered through REDCap. We sent a REDCap link to the local health department administrator, and that administrator completed about 12 questions. It was relatively short. The questions looked at recruitment strategies, how many employees have turned over or left that were not COVID related within the last 2 years. We asked about organizational needs, partnerships within their community, as well as any training needs that they have in their organization. So once each health department provided us their Excel sheet and their organizational survey, we conducted a qualitative interview. And these qualitative interviews were held over Zoom with at least 2 members of our team. one person conducting the interview and one individual taking notes. And we worked with the administrators to go back through the information that they provided in their Excel sheet and the survey. For every one of these interviews, we created a summary PowerPoint of what they shared with us so that we could confirm and clarify the information that we received and make sure that we had the appropriate context and insight from the individuals that are in the know in each of these organizations. The fourth component of our data collection was a job description request. So if the agency had job descriptions, we asked that they share them with us. We didn't want them to go through extra work and create things that didn't exist already, but we said it would be helpful for us to have their job descriptions if they already existed. One of the ways that we were able to encourage health departments to participate was by providing an incentive. So the first two components, the workforce assessment and the organizational survey, were equivalent to a $600 incentive if they were both completed. The qualitative interview was another $250, and if they were able to provide us some job descriptions, another $150 was included, for a potential total of $1,000 for participating in the workforce assessment. For the Excel sheets, we had incredible response. 97.9% of our local health departments were represented. 93 out of our 95 local health departments participated, which covered almost 99.4% of the state's population of the public health workforce representing them. For the organizational survey, 96.8% of our local health departments provided the REDCap survey responses, 92 out of 95. For the qualitative interviews, we invited anyone who wanted to participate, but we did have an end date of the end of November of last year. And so at that point, we had 70 interviews scheduled, which represented 74% of our local health departments across the state. As I mentioned, we developed our tools in collaboration with the Indiana Department of Health. We piloted these tools with a handful of administrators in local health departments, and based on their feedback, we refined them. We crafted a letter that was jointly signed by the state health commissioner and the dean of the Fairbanks School of Public Health. The letters were emailed to the local health department administrators and to health officials for each of our local health departments. Our list and contact information was provided through the Indiana Department of Health as our key partner and funder, and we participated in Indiana Department of Health-led virtual monthly meetings that they already have with their local health administrators. We created a FAQ, a frequently asked questions form, which we disseminated along with our invitation to participate. And then we provided a Qualtrics link for local health departments to submit any questions or technical assistance requests. And we also, Dr. Hiltz and I both provided our individual emails. So if anyone had any questions, they could reach out to us directly. As a result of these efforts, we were able to collect information from over 2,000 local health department employees in the state of Indiana. So for the first time, Indiana had a count of how many individuals are working in the local health department setting. This equated to 1,897.6 full-time equivalent staff, and on average, that's 3.0 local public health employees for every 10,000 residents. By having this information, we could then look by the size of the population served, and that's how the vast majority of the data is presented in our local health department assessment. We present it at the district level. We have 10 preparedness districts in our state, and we also present it by the size of the population that the local health department served. And that was based on feedback from the locals that told us that it's helpful to see how similarly sized populations serving health departments are structured and how many employees they have. So they wanted the information presented so they could compare themselves to similar local health departments. You can see that we've presented it that way in this graph, which we pulled out of our report. And we also are able to then compare some of this data at the national level based on Public Health Wins 2021 data. So nationally, at the local health department setting, there are 4.1 FTEs per 10,000 people, but in Indiana, the average is 3.1. So we had fewer full-time equivalent employees in the local health department setting per capita than the national average. A couple key lessons that we began learning as we went through this process was that there is a lack of standardization. I don't think we were surprised by this, but we also weren't always able to head it off before we realized the implications of it. So it's important for us to shine some light on the challenges that we had because we think it will help others if they're going through similar assessments. Some employees indicated that they were full-time and part-time. We asked for full-time or part-time, permanent or temporary. We also asked if individuals were seasonal, a paid intern, or a county hired 1099 contractor, or specifically an employee that does not have benefits. But there was substantial variability in how these classifications were implemented or assigned in the worksheets. In instances where an employee was assigned as a seasonal or a paid intern or a county hired contractor, but they did not complete whether they were full or part-time or permanent or temporary, we employed a decision rule consistently throughout all of the data to make sure that we were thinking about each individual in the same way. So we based our decision rule on the number of hours that the individual reported working per week, a very important variable to make sure you collect. And if the salaries were funded by grant dollars, that further helped us make a decision. So we asked what % of every employee is funded by a grant dollar, what % of that employee is funded by grant dollars. And in Indiana, if someone is 100% grant dollars and they say that they are part-time and they're working 15 hours a week, we would then assign them as a temporary employee. Because they were 100% on grant dollars, we made the assumption that they were not a permanent employee. Clarifying some of this language so that individuals who complete these assessments consistently is really important. We have made changes to our data collection tools to reflect some of the clarification that is needed. And we've shared our data collection tools on our school website, which is linked at the end of today's presentation for anyone else who'd like to use it. Our full report is also on the website. The construct of a contractor also varied across individuals surveyed. So clarity and consistency around what a contractor means, including 1099 staff, as well as individuals who are paid by local health department money that is subcontracted to another organization. So this is where there's a little bit of gray and confusion around who is technically a contractor, but having clear definitions about this is really important so that everyone approaches it the same way. Additionally, when we assigned full-time effort, we found that local health departments differed in their organizational definition of what full-time is. In fact, across our state, full-time ranged from 32 hours to 40 hours a week by organizational definition. So this was an important consideration when we were going to be comparing average salaries across different roles. So the last thing that we had to do to make consistent comparisons for all of our data analyses was the title of each individual. As you can imagine, in different health departments, roles have different titles, but those individuals might be doing similar things. So if we only collected the name of their role, we wouldn't have enough information to make assumptions about what they actually do. So we accounted for this by asking each individual to tell us their top 3 most common job tasks. And we used job tasks that were available in a standard list through PHWinds. And based on the title they provided us for their role and their 3 most common job tasks, we used 2 members of our team who have experience working in the local health department setting to assign a standardized title to each local health department employee. That means 2,086 people got a standardized title based on those top 3 job tasks and what their title is called in their agency. Some individuals only got 1 role, but if they had dual roles, they got a primary role and a secondary role based on what % of their time is dedicated to certain tasks. So if they said they were an administrator and a public health nurse, and some of the work that they did was nursing, but a good portion of it was administration, their primary role may have been an administrator, and their secondary role would have been public health nurse. I will pass to my colleague, Dr. Hiltz.
Hi, thanks. And I'm going to try and go through some of these slides pretty quickly. We capture a little bit more information about our workforce, common jobs. So environmental health workers were the most common job. As Dr. Yeager mentioned, we did collect kind of secondary roles that they did, and we saw that about 7% of our workers did serve in a secondary role. Moving on to the next one. Some of the other things we looked at, as Dr. Yeager mentioned, were common roles, so public health nurses, but also those funded by grants, which was about almost 30%. And then 4% of LHD employees were contractors, although this may be unclear depending on definitions. And then I'll just walk through some of the other things that we were able to do. So again, we did have information that we could connect this to compare to Region 5 and national levels. So if you want to go on to the next one, Val, and to the next one. So we were able to look at certain things compared to our kind of national and Region 5. And this just gives you that. I'm not going to go into detail on this, but basically our workforce in Indiana, public health workforce, has less formal public health training and advanced degrees in public health than other workers in our neighboring states in Region 5. So this was important for us to kind of understand and giving that benchmarking and where we can go. And next slide. We did also collect salary. I will note that while we have Region 5 salary and did have some of those comparisons based on feedback, as Val mentioned, a lot of our local health departments were more interested in how they can compare to others, also looking at that salary by length of employment and education to see how those varied. So that's how our data is compared in this. So while I said we do have some comparisons for Region 5, primarily in our tables, a lot of this is by those other ones. So we'll quickly look at what that looked like. So this is just an example of that salary by role, looking at experience and degrees, public health degrees and education level. And then the next one. So then this was an example of a table looking at kind of education level as well as comparisons by size. I will note that we didn't always see clear trends in this. So really looking at how there is variability across the different localities and how salary is assigned regardless of these kind of different metrics. So next one. Another big thing we looked at were the foundational public health services and capacity towards those. So we did ask respondents to estimate their % of effort or time spent towards these areas. So we then were able to take this information, so if you want to go to the next one, and put it into the public health workforce calculator. So this just kind of gave us an estimate of what the capacity needs were for Indiana, and we did aggregate this up to the state level. So next, for both areas and capabilities, we found that we were lacking in most areas. So 4 out of 5 of the areas, and then 6 out of 8 of the foundational public health service capabilities. I will note, if going on to the next one, this was difficult. Many employees felt that their job tasks didn't align well. So this did make some issues in being able to appropriately assign it, which likely contributed to an overestimation of effort in the calculator. So seeing that we're still kind of low on that, that's important to note. So really need some further consideration of how to better align or integrate these within current practice moving forward. So next.
And Katie, we also, in our Excel sheet where we were collecting this information, we had a page dedicated to definitions for each area and capability and example activities that fell within each of these areas so that people weren't left guessing whether or not their work aligned with an area or a capability. But still, there was some question about how their work fit within those.
And then as part of our surveys, we did ask about retention and reasons for individuals leaving health departments. These were outside of COVID or retirement, or outside of COVID, I guess, hires, the temporary hires. So as you see, pay, workload, burnout, and retirement were the top three, with stress following that. So these did also align with some national findings and weren't surprising. It was important to note that we do have a lot of folks planning retire, with certain areas in our state, districts 6 and 7, having a higher kind of percentage, almost a quarter of the workforce planning to retire within the next 5 years. So definitely areas to consider how we can build capacity in those places. Again, these were looking at training needs and what could be used to help kind of further support local health departments and their employees. So this gives you an example of what those top priorities were across LHDs in Indiana. And then the next one, one of the big things we really wanted to do was make sure that we had data, and you'll hear from one of the local health officers, but data that was specific to counties that they could use. So we did create a report that we sent out to them, giving them kind of a summary of their information, but also comparing them to like-sized health departments in Indiana. So every health department that participated in any parts of this did receive this data so that they could look at it. Well, I guess the Excel assessment.
And it was a little longer than just the 2 pages we're showing here. And these were only provided to the administrators. We didn't make these public for everyone. Administrators could work with whomever in their county official positions to propose changes. And
then so kind of wrapping it up, we'll have a couple quick more slides. I think what Val had mentioned, that, you know, one of the really great things is this is the first time that we have had this comprehensive look at, you know, the number of governmental public health employees in Indiana, and, you know, really giving an opportunity to compare strengths and weaknesses among staffing levels and services provided, and to inform ongoing efforts and new efforts to kind of strengthen our public health system in this state. Again, this can be used to track changes over time as these efforts happen. So some lessons learned, again, some of those concerns that were expressed about aligning job tasks with areas and capabilities and thinking about how that can be addressed in the future. I will note that one of the things that the state has also done that we did with them was to look at the state level employee workforce. So we did, again, an individual workforce. We also did focus groups with staff to kind of understand their needs and barriers to success. And then also some small group interviews with division directors and assistant commissioners. And this gives you a look at, you know, the response rates of 76% of the staff participate in those surveys. We had 7 focus groups with 45 participants across 24 divisions, and then 15 interviews, 3 people in each, for a total of 45 participants in those small group interviews. And so this data can really be combined with that, with the state, to kind of help inform their ongoing efforts to make sure they're strengthening kind of the whole workforce and governmental public health system in Indiana. Again, just some of the things that were already brought up. One of the big issues is lack of standardization, and hopefully some of these ongoing efforts with Pam and her team can help to address some of these issues moving forward. And we took up some of Pam and Dr. Yazel's time, so we will hand it over to Pam to talk about kind of their plans with this information.
Thank you so much, Katie. I really appreciate you and Valerie being on today and sharing what all you did with the workforce assessment. Certainly at the Indiana Department of Health, we're grateful for your partnership. And we did enter into this collaboration with the IU Fairbanks School of Public Health based on the skill sets that they are able to bring to the table, the history they have with researching Indiana's public health system, and our previous partnerships. So they were an outstanding partner in this effort. And I also want to mention that this work was supported through the CDC Public Health Infrastructure Grant, both the local health department assessment as well as our internal state health department workforce assessment. You heard Dr. Yeager mention at the beginning that the Governor's Public Health Commission did issue its final report of recommendations in July of 2022. And this report included 32 recommendations based on the information and considerations that were presented throughout the work of this commission. One of the top recommendations was the development of a set of core public health services that our local health departments would be expected to deliver no matter where you are in Indiana, so that all Hoosiers have access to core public health services that are modeled on the foundational public health services. Along with the Governor's Public Health Commission report, which was a legislative request that was made in the past legislative budget session beginning in January, led by our state health commissioner at the time, Dr. Chris Box, our legislative team, partners, and many others, to request direct, recurrent, stable funding for public health in Indiana, both at the local and the state levels. And this ask was made for funding directly to local health departments to support core public health service delivery, and then also to build out some of the programs here at the Indiana Department of Health. On April 27th, the Indiana General Assembly appropriated $75 million to support our 95 local health departments for 2024, and then doubling to $150 million in fiscal year 2025. This was really an unprecedented allocation of state funding directly to public health. And this is a non-reverting fund, so it cannot be apportioned to other activities like transportation or education or something else. That compares to the historical annual state appropriation of $6.9 million that our 95 local health departments would divide up and use annually for the past 20 years. So this was really a sea change in state funding support for public health in Indiana. Part of the core public health service delivery includes the maintenance of key staff, such as a full-time or at least a half-time preparedness coordinator, a full-time public health nurse, and a full-time school health liaison. So local health departments were able to use the data from this really first of its kind workforce report for local health departments to be able to plan and budget for how they would spend their state appropriation from this new allocation from our General Assembly, to really look at how best to support their staffing, whether that was hiring of new county staff for local health departments or contractual staff, really to level set the numbers, and then also looking at the skill sets around the foundational public health services. So really using this data to make data-driven decisions of how they are going to spend this new funding in upcoming years 2024 and 2025. And with that, I will turn the program over to Dr. Eric Yazel, the health officer of Clark County Health Department in southeastern Indiana, to give you more information on how these data are being used at the local level.
Thanks, Pam. I appreciate it. And yeah, so you guys have seen all the hard work that's gone into developing a report like this. And so once that's available, what do you do at the local level, boots on the ground, to make this work for you? And yeah, Clark County, Indiana is down in the southern part of the state, right up on the Ohio River. We have about 125,000 people, and we cover 300 square miles. The picture there shows we do have an interesting population dynamic. I always say we have 125,000 people, and 124,000 are right up on the Ohio River, and then the rest of the county is very rural. And so I think we mimic a lot of other areas because we have both rural and urban problems. And also we provide all the services of a larger health department without a lot of the resources because we're still smaller. So first thing that we think about when we're implementing these is just the groundwork. What do you need to do? And I think it's important to have a strong history in your area. We've always had the philosophy of being more of a supportive than just a straight regulatory agency. And so that's how you begin to list your general populace when you want to implement a workforce study like this. Also, visibility. We get out to every single community event, and we're visible where people see us, they know what we do, and things like that. When I first took over, a lot of times we heard, what does the health department actually do? And no one's going to help you from a funding or workforce side of things if they're not familiar with that. Next thing is preliminary discussions. You want to sit down with your local elected officials and funders. Let them know about this workforce study, what it says, what you'd like to do with it, and things like that. In a public meeting, my goal is there should never be any surprises. So you want to make sure they know what your ask is going to be and that they understand how you want to implement this data that you're sharing with them. And then the last one I put is preparation as well. And again, I think a lot of people see a workforce study like this and just want to hand it to somebody and say, okay, here you go. This tells us where we need to be. And there's a lot of other work that needs to go into making a study like this work for you. And then so when you do implement, obviously you guys know the setup on this, but you have to go through your county commissioners. They're kind of the gatekeepers. There's been some trepidation between county commissioners and public health, at least in the state of Indiana, and left over from some pandemic dynamics and things like that. And so we were lucky enough to have really, really good, strong leadership at the state level and wonderful elected officials at the local level that we were able to bypass some of that. But again, just the outreach and things like that is important. Again, engaging your county councils, your elected officials, and also local stakeholders. Let them know, hey, there's been a work study. We're asking for A, B, and C. Everybody's asking for funding at the local level, and having someone else advocate for you and say, hey, I saw their work study and they need more FTEs or better compensation. Engaging other stakeholders on your behalf can really go a long way to success. So what barriers did we run into? We talked about a little bit, some post-pandemic public health perceptions. There's a lot of thoughts about overstepping and things like that. And then here we are with more funding and going to ask for more positions and higher salaries and things like that. The local fiscal situation, budgets are tight everywhere, and then a lot of times when I'd explain some of the governor's public health funding, I was a lot of, well, where's the catch? You're getting this new funding, but what happens in a few years if that funding's not there or things like that? And so, that was something we had to overcome as well. And probably one of the biggest challenges was just congruence with salaries of other county agencies. You'd hear, well, the court system has this employee who's making, this, what's your job descriptions that justify higher compensations? And so that was another challenge that we had to navigate. So how do we do it? Well, number one, we already did our legwork. We reached out to everybody that was going to be listening to the work study and what we wanted from it. We built those relationships. We elicited support out in the community, had those preliminary discussions. Every single county commissioner and county council member had already heard from us and knew this was coming when budget time hit. said, hey, do you have any concerns about this? Anything that we can clarify for you? And went from there. Just the quality of report. We have an outstanding, just so many resources put into a quality report to share with them that shows that this just isn't us shooting from the hip. This is, real quality data behind that. I think maybe most important of all is describing it as a market adjustment instead of raise. The perceptions of things are totally different, and functionality as well. We're saying, hey, we just want to be commiserate, with other areas around us and things like that. We're not just getting this new funding and padding everybody's, salaries there. And I think that was really, really important. And then also using this to kind of enhance our job descriptions. We looked at what other areas do, and we did a lot of cross training during the pandemic. And so a lot of us were forced to look into new roles that maybe we hadn't had in the past. And adding that to the job description, made all those positions look more professional, so that when you do reach out for a market adjustment, that's well received. And so some of the results, our final budget's pending, so I can't say it's all done, but what we've got in right now is significant increases. Some salary increases of up to 5 digits as a result, direct result of this work study and things like that. Improved job descriptions. And then probably most importantly, just morale in general. I always say you can only throw so many pizza parties for your employees. They've seen that the hard work that went into a job study. They've seen how hard we advocated to implement what we found in that work study at the local level. They see them fighting for you. And, I'm really proud to say that we have not lost a core staff member since the pandemic. And I think it's a result of going to bat for them, using real data and advocating at the local level to implement the things that we found from everybody's hard work. That's just a quick overview. I could probably sit here and talk for days, but that's a quick overview on how we put this to work at the local level. And again, I appreciate everybody's hard work that gave us this study and the leadership at the state level that allowed us to be where we are today. So, thank you.
Thanks, Dr. Hazel. Greetings, everyone. My name is Ashley Nanthavongsa Mosley, Senior Analyst Workforce at ASTO. Before we kick it to Q&A, I'm just going to go over some resources that we have that we're going to share with you after this call, 2 of which are the tools for Indiana's assessment, which you can download, and also their new paper about the lessons learned from Indiana's workforce assessment. Next slide. Second resource is from ASTO. If you all haven't heard of publichealthcareers.org, it's a website devoted to careers specifically in governmental public health. And if you would like your vacancies on there, please feel free to contact us at workforce@asto.org. Next slide. The next resources are from NACCHO. The Individual Development Plan Guide allows members of the public health workforce to identify skills to build and provides a way to measure attainment of skills and completion of learning tasks. And their second resource is a Workforce Resource Center, tools and resources to help your team develop your skills related to accreditation, public health competencies, and more. Next slide. And lastly, from FAB, the Public Health Workforce Calculator is a tool to help local health departments with workforce planning efforts by utilizing information provided about the local health department to estimate the number of FTEs needed to ensure the provision of the foundational public health services. And the calculator is intended for use in decentralized public health systems that serve less than 500,000 residents. The second resource is their FPHS capacity and cost assessment, a tool to help health departments and health department systems assessing their current spending and capacity towards the FPHSs. So without further ado, I'm going to go ahead and kick it to Kathleen for Q&A.
So much, Ashley. Hello, everybody. My name is Kathleen Szymanski, and I am a senior program analyst on workforce development here at NACCHO. So we just want to thank everybody for being here today on this lovely Monday afternoon, to our wonderful presenters and to all of our participants. It's such an interesting topic and so important. So I am just going to start, and I'm going to present some of the questions that were posed and kick it to some of our presenters who feel that they are best equipped to answer, which is probably all of you. Our first question, though, we've got for today is how might the tools and or approach be adapted for a local urban health jurisdiction serving a population greater than 500,000? Sounds as if perhaps Dr. Yeager and Dr. Hiltz might be able to jump to that.
Sure. So we have an incredibly large health department in Marion County, and we worked with the various leadership across Marion County's agency. The health official for Marion County asked all of her leaders to get on a Zoom call with us. We talked through what the assessment looks like, and they decided that they would give each of their division directors the responsibility to have the folks within their, sorry, is it department, Katie, or division?
Departments.
Their department directors, the responsibility to collect individual level data from each of the individuals in their departments. So they just saved a new file of the Excel sheet, and then each person worked within their department to get that information. And then they sent each of those sheets back to us. So it was almost as if it was however many small health departments within a large health department. As you saw from our state data, we had a lower response rate when we created an online survey to collect the same information that we collected in the Excel tool. So your response rates do decrease when you put the responsibility on the individual with no leadership coming to them saying, hey, I don't yet have you in our spreadsheet. And for one of the requests for us for assessing the state workforce was that their findings, that what they share with us be private. And so it wasn't as if we could then say, these are the people we don't have responses from. We did have a way to track, but it then led to questions about, well, how is it private if they know I didn't complete it yet? So I actually prefer the Excel tool if I were doing this again. But we did get 70% response from the state health department employees, which is still a really great response rate. And that was due to Pam and other leaders in the agency asking, and we sent numerous survey requests out to those who hadn't yet completed the survey. Did I forget anything, Katie?
No, and I would say, yeah. So we did have a good response from Marion County as far as that large health department. So I think, and they cover over 800,000, I think. So so I think we could also probably connect you with them if there was interest in talking about how the experience went on that.
Wonderful, thank you. Our next question in the chat was, somebody was wondering which indicators you all use to adjust for salary in your analysis.
So really with salary, primarily we get standardized based on hours that were full-time equivalent by health departments. So that did vary across those. I will say we didn't do any kind of market analysis or anything for standardizing across, kind of jurisdictions or areas. So primarily it was just adjusting based on those full-time hours so that we could standardize that and create an annualized salary. And we did only include the full-time employees to stay consistent with how the public health WINS collected that data and reported that data. We did also have to put them into categories to have that comparison. So that was the primary way we adjusted for salary data in our analyses.
Great, thank you. Our next question, so if somebody poses, we are drafting our workforce development goals now. Do you have any advice for how to encourage all health departments, local and state, to feel a sense of ownership over the plan? Sounds like perhaps this might be well suited for Pam or anybody else.
Hi, thank you for your question. Thanks, Kathleen. One of the things that we did here, and I think is really important then to help folks feel ownership of the plan is to bring them to the table. To bring them to the table when you first start down the development path. That here's what we're thinking about, here's why, here's the goal, here's the information behind it. What do you think? What would you hope to get out of this? How do you think is best to assess this and develop it? One of the things that, we built that pretty early with the local health department workforce assessment by getting input and feedback from local health departments on how this was being built, what types of questions, what would be useful for them in building this, and information that they would want to hear about and be able to take back to their stakeholders or local elected officials in being able to serve them that way. Same thing with our state workforce assessment. When we embarked on that, is explaining the why, how it differs from PH wins, how what we plan to do with the data, and then making sure that as you go through the process that you update folks where you are with development as you are distributing it, making sure that they are aware that it's going out, what the deadlines are, following up if you are seeing that maybe you haven't heard from groups yet, sending reminders. And then once the data are analyzed, getting that data back. One of the questions we get is, okay, what did you do with this? We gave you this data. Now, what did you do? We haven't heard anything. So making sure that folks get communication regularly about what the next steps are, what we're doing with this, how are we using the data now to inform our practices, and would love to get input from Dr. Yazel on that as well.
Yeah, that was what I was going to say, to be honest with you. Not brown nosing here, but the communication between the state and the local level is outstanding. And I think that's why, that shows in some of the high return rates on the surveys, because I think we all get surveyed to death. And a lot of times those surveys go off into whereabouts unknown, and you never hear anything on the back end. And IDOH did a great job of saying, okay, here's what we want to do and why. And then every step of the way saying, here's where we're at. And at the end, here's that data, show us how you're going to utilize that, and give us some cool success stories. And so I think that legwork is exactly why we had such a high return rate, and so important.
And it's not something you're going to do every year. And if people can see how the data and the effort that they put into it is used, then redoing it, especially after such important investments are being made in system strengthening in our state. If we did this in 5 years or 10 years, we have baseline data that we can compare from before these major resource investments to after. And we also have, as a result of the new funding through Health First Indiana and our General Assembly, some key performance indicators that are going to be tracked to see what some of the outcomes are of strengthening the system. So it's not just how many employees do we now have compared to before, but we'll be able to link some of the key outcomes for the community's health and certain public health activities with these system improvements.
All right, thank you all. Our next question is, and I'm assuming I've got the acronym correct, so if whoever asked this, please correct me if I don't have it. But I believe the question is, why were foundational public health services not included in the process for state level employees? FPHS is relevant to both local and state health departments.
So the foundational public health services are primarily targeted at local public health delivery of services. Much of the work that the state does supports the locals in those areas and capabilities, but it doesn't map directly to the provision of the foundational public health services and capabilities. And I see Rena has turned on her camera, and maybe she'd like to add in the perspective from FAB and PHNCI.
Yeah, happy to do so. I think that's a great kind of response to, in particular, to Indiana's circumstances in terms of how the governmental public health system operates in Indiana. I think if you look both at the National Foundational Public Health Services framework, it really is a description of what the governmental public health system should be providing everywhere for public health to work anywhere. And what we see state to state currently is how that service delivery happens differs based on kind of that individual state's circumstances. What we're trying to get to is an understanding, how can we communicate collectively collectively about what is available everywhere for public health to work anywhere across the country. But where it's kind of incremental. So I think if you were to look at other states, there might be more foundational capabilities in areas that are provided directly by the state health department or the local health department, depending again on how that service delivery is organized for that state context. So just wanted to provide that kind of national perspective in addition to kind of the Indiana specific work.
One thing I will piggyback on, thank you very much, Dr. Yeager and Rena, is that in our state workforce assessment, when the interviews were being conducted and focus groups, we did look for commonalities of what types of activities people were doing, where we were seeing common programming being delivered or overseen by different divisions here. That information has actually led to some of development of innovation teams, cross-divisional teams that are working now, pulling together on the work that they're doing in those common foundational public health service spaces. So that is an area where we saw some really good information and data coming out of that on the state level.
All right, thank you all for chiming in. We've continued to have some really good questions come in. And somebody said next is, it may be evident once I dig into the tools, but could you explain how you assess staff capacity against each of the FPHS? I'm interested in the nuts and bolts of how you did this.
Sure. So when you download our Excel tool, you will see that there are 5 different tabs in the Excel data collection sheet. The first tab is general instructions for the entire process. The second tab is the individual level lines for each employee's role and then each variable across the columns. The third tab is where we provide information about the areas, and the fourth tab, the capabilities. So we provide a definition for each and then individual activities that would naturally align with each of the areas and each of the capabilities. And we gave instructions in how to think about it. We also made it so that no one could report more than 100% of their time towards the activities collectively. So we built some rules into the Excel spreadsheet so that you couldn't incorrectly say you were providing 200% of your time towards an area. So it had to be able to add up to 100%. We also did try to say, we recognize that you feel some social desirability to meet the letter of this request, that foundational public health services be provided in every community. But we also recognize that not everything you do fits perfectly with these. So your staff shouldn't feel like they have to give 100% of their time to everything. But even though we said that, both in written form and in some of our communication by email, I still think that they may have had a need to look like they're doing the foundational services as much as possible. So there's still this sense of not wanting to look like you're not providing what your community needs. And I think we are going to, as a collective of individuals who are supporting health departments, work through this. Not everything that's provided by a local health department is the foundational services and capabilities and areas. But again, we gave as much instruction as we possibly could. Katie, do you want to add anything else that you thought about?
Yeah, I was just going to say, so one, we also did it in one of the webinars. We went through the kind of Excel and we gave an example. I actually was a former local health department employee and I use myself as an example. We really asked them to say kind of in a normal week, how would you do this? So that was one, we gave them the context of what we were wanting. And as Val said, in multiple different ways, we tried to reiterate, we don't necessarily expect you to commit all of your time, let alone 100% of your time to these areas. So we try to emphasize that and even give examples of certain physicians that may not see any of this, right? So that people would know, but it was definitely difficult. I don't think it's how currently a lot of folks in local health departments think. And so I think that is something that can be kind of looked towards as how we can help them in understanding this as we move forward with efforts.
Well, thank you both, Dr. Hiltz and Dr. Yeager. Our next question is twofold. The first is, was there any data collected on the Indiana community health workers as part of the assessment? And what is the available information to share on the Indiana community health workers? Appreciate any insight.
So we did not explicitly collect, although, to the extent that they are represented in these local health departments, the data would be in there. I can't off the top of my head tell you what percent had community health workers. My gut, it would be in the larger ones and may not be in some of our smaller ones at this point. So yeah, this wasn't an explicit focus, but I do believe there were some community health workers represented in the data.
We have actually 61 community health workers represented across the state's local setting. But as I mentioned in my section of the slides, we assigned each individual a specific role based on their 3 most common job tasks. And community health worker was one of the roles that we assigned. Some of the community health workers had a secondary role. The most common secondary role was public information specialist. But if needed, you could look through the report, and anywhere where we break down information by role, you can dig into information specific to a type of role that you're interested in. So environmental health workers turned out to be the most common position in our state. And we can look through and look at information about individual types of roles in the report. And that report is, the full PDF of the report is about 100 pages. And you can download it from our school's website at that link that I think was provided in the chat and was also in the slides. Did we answer all of the question? Was there a second question?
I believe so. The second part was what is the available information to share on Indiana community health workers?
Right.
And our second, so we've got 2 more questions and we're right on time. I believe this one is likely for Pam. What were the most important elements relating to ultimate success to the legislative ask?
Hi there. Thank you so much for your question. And there were several actually that I think contributed to the success of that ask. First of all was the Blue Ribbon Governor's Public Health Commission and the foresight of our governor to pull that together, to really be thoughtful in selecting the members of that, their varied perspectives, their support of this effort, showing the data to our legislators, especially in their districts, of how they fare in different public health indicators, the health disparities that we see. One notable one is that of life expectancy in Indiana. There is a 9-year difference in average life expectancy in our state from the top county to the lowest county. 9 years difference. So a big geographic disparity and lots of reasons, of factors that feed into that. Speaking the language, sharing really what matters to our audiences, and engaging our subject matter experts, advocates with local elected officials and state lawmakers who saw the value, and being able to work with them to share the value of the funding and how this would be put to use. Getting support through engaging associations like the Association of Indiana Counties, the Indiana Association of County Commissioners, engaging in presentations with businesses, with state lawmakers, non-for-profits, any partners who wanted presentations, speaking at meetings, one-on-one phone calls, conversations with anyone who wanted to find out more information about why this funding would be so important, how it would be used. And then engaging in community listening tours. We held 7 of those in different areas of the state to get input from the public. I think really key was preserving local control. So really at the heart of the legislation that was the genesis of this funding was that local elected officials, the county commissioners, got to choose whether or not to accept this new appropriated funding. This was not a state mandate. This was not driven by the state. But as we mentioned, Indiana is decentralized. So the local officials, the local health departments have the legal authority over public health in their jurisdictions. And I think having that ability to opt in was very, very important. And following the same approvals for any other budget that our counties normally would have, getting approval through their county councils. And at the end of the day, 86 of our 92 counties opted into this funding. So that means that 96% of Indiana's population is now covered by our Health First Indiana funding. The funding is flexible. It is not prescriptive. The only requirement is that the funding be used in the provision of core public health service delivery. And that's really it. That counties themselves, local health departments, in conjunction with their local elected officials and partners, decide how they want to spend the money. There's no prescription. There's no formula that says you have to spend so much on this and so much on that and this particular type of program and this particular framework. Counties get to decide with their partners, and being able to use partners in the community to contract with them to provide core public health services or maybe expand what they're already doing. It's really up to the local jurisdiction to decide, and that might also be a shared service model. If one local health department has more experience or resources in a particular area, for example, TB prevention, then they could engage in a partnership with maybe a smaller county that has 1 or 2 cases a year to help them provide that service in exchange for some funding to do so. And then I think key also are the provisions that we had built in to show return on investment. So this is a true investment of taxpayer dollars. We want to be good stewards of those and show what we're doing with that funding. I, as a taxpayer, would want to see that also. So we have formulated state level key performance indicators. Counties will be developing their local level key performance indicators next year. Counties will be reporting on those state level indicators twice each year. They will also be issuing a budget report annually on how they spend the funds, and then also sharing success stories, making sure to invite local lawmakers, local elected officials, state lawmakers, the media, to events that they have where this funding is being used to really show the return on investment, because that's what it truly is an investment in public health. So I think those collectively were really instrumental in the success of that legislative funding ask.
Do you have any external documents about the core services that Health First Indiana is covering? I saw a question in the chat about that.
Yes, we do have quite a few resources, visuals, documents that are posted at healthfirstindiana.com, and I'll put that in the chat. Healthfirstindiana.com is the hub, the website hub of all of the Governor Public Health Commission recommendations, the legislative funding, the legislation itself, to really show how this funding was developed, how it can be used, kind of the resources that are available to those counties that have opted in. And even if a county opted out, that's not a one and done deal. A county can decide to opt in next year or in the future if it wishes to do so. So Health First Indiana is the name of this effort, because we know that when we put health first, good things happen. That when folks are healthy, they're more productive, they're at work, students learn better. So by putting health first, that's really the foundation of future success. It's also the first large appropriation of state funding into public health in Indiana. So really proud of that work, and putting that in the chat right now so you can visit that website.
So much for all these wonderful questions and such detailed responses. I'm sure we could just keep keep answering some of these because they're just really so interesting and really helpful. So with that, thank you, our presenters, and I will pass it back to my dear friend and colleague, Ashley at ASTO, for our closing up.
Thanks so much, Kathleen. And thank you so much to our presenters and Fab for putting this together with 1 minute to spare. Just wanted to let everyone know, thank you so much for being here. The resources, the PowerPoint, and the survey is going to be sent to you after this call. Again, thank you all so much for being here today, and have a great week, everyone.